Hi everybody, we're going to continue with your PowerPoints on electrical impulses. What we discussed on the previous PowerPoint was the electrical impulses or the action potential created in your contractile cells. And if you guys remember, the three steps that we discussed was starting with action potential of the non-contractile cells, which leads to action potential of the contractile cells, and that leads to basically muscle contraction. So in this picture, what we're focusing on, you see the action potential of the contractile cells in the blue line, which is basically resting, depolarization, plateau, and then repolarization. And you also can see the contractile phase of the cardiac muscle right here. What you see in the red line, following it, you see that the muscle of the heart is contracting during the plateau phase, and then as you start to repolarize your contractile muscles, your muscle contraction is also coming to an end. And then that means that basically this is representing ventricular, your contraction of the myocardium as a result of the action potential of the contractile cells. Now, following up with that, you do need to understand that electrical impulses that are created by your pacemaker or by your non-contractile cells or your pacemaker cells can actually be detected from the surface of the skin using a machine called the electrocardiograph, and it can be recorded on basically a recording or a graph that is referred to as the electrocardiogram, which is typically known to public as ECG or EKG. The way you accomplish the measurements and basically recording of these data, you use 12 leads of the ECG. That is typically, majority of them are going underneath the heart, moving toward the left of the thoracic cavity. So basically you're tracing the action potential of the heart by going basically underneath the pectoralis major muscle underneath the heart and going to the left side of the heart. You also have additional leads that are going to the superior part of the thorax and the inferior part of the thorax that makes up the 12 leads. Now, if you're looking at a normal ECG has the following components. It has three main key components if you want to look at them. It has a structure which referred to as the P wave. You have this very pronounced structure which is known as the QRS complex. Right here, QRS complex. And then you have this last one, the bump, that is called the T wave. Now, to make sense of the information I have here, let's write about a couple of key points that you need to know. If you look at your heart, atria, which are basically the top chambers of the heart, must contract first. To basically, their goal is to fill ventricles with blood. So, if I want to contract my atria, I need to send action potential first through the atria. The other point that you need to understand is the two main steps of the electrical impulses or action potentials are depolarization and repolarization, which both can be measured on the ECG. So because we have two main sets of chambers, atria and ventricle, each of them have their own depolarization and repolarization. So the four steps basically would start with depolarization of the atria, followed by repolarization of the atria. You also will have depolarization of the ventricle, and lastly, repolarization of the ventricle. For you guys to understand and practice that, you can kind of think about the picture you have below for the intrinsic conduction system that starts with the SA node, goes to the AV node, goes down to do the AV bundle, bundle branches, and eventually spreads through the Purkinje fiber. So what you have here, let's look at the steps. Depolarization of the atria has been represented with your P wave, which is basically the first structure you will see in your ECG. The next structure that's going to be visible to you is depolarization of the ventricle, which is represented as this very pronounced structure called the QRS complex. It is going to be larger because ventricles are larger. They have more elaborate networks of non-contractile cells. Therefore, the electrical impulses will be more pronounced. And then lastly, we have repolarization of the ventricle, which is represented by your T wave. Notice that we are missing the repolarization of the atria. And the reason for this is that it's not that your atria does not repolarize. That's a wrong assumption. It does repolarize, but it happens that repolarization phase happens sometimes during this part, which basically means that atrial repolarization is overshadowed by what? Your QRS complex. So again, don't assume just because it's not present on the ECG, your heart is not repolarizing, or more specifically, your atria is not repolarizing. They are. It's just that process is overshadowed by a much larger electrical impulse created as a result of ventricular depolarization. Here's a good description. I'm not going to spend more time on this, but you do need to kind of glance through this to have a better understanding of the intrinsic conduction system, which is represented on the left-hand side, and relate that to your ECG. Now, within your electrocardiogram, you also have additional components, which is the PR interval. So right here, this is your PR interval, starting from the beginning of the P wave all the way to the beginning of the QRS complex. This is known as the PR interval. And it represents the atrial excitation to the beginning of the ventricular excitation, which should make sense since this is representing depolarization, and basically that's followed by depolarization of the ventricles. The second segment you see, or section you see, is the ST segment, which basically is the flat line between the QRS complex and the T wave. This is the region that is basically enables what is happening is when your myocardium of the ventricles are basically being fully depolarized, and basically the electrical impulses are spreading throughout your ventricles. Last part that you have is the area that starts from the QRS complex and ends with the T wave, which is known as the QT interval. This represents the ventricular depolarization all the way to when your ventriculars is fully repolarized, which makes sense because this is depolarization, this is repolarization of the ventricle. So again, QT interval is representative of ventricular depolarization all the way through ventricular repolarization. So, knowing those and knowing what the normal ECG looks like, let's go ahead and take a look at the variation that you will see in different medical conditions and things that are going to be visible and monitored on an ECG. So in the first picture, what you see is a normal heartbeat, which contains, which we also call it the sinus rhythm, which contains P wave, QRS and T wave in equal ratio. So if you follow P, QRS, T, P, QRS, T, P, again, QRS, T. They are followed, everything is 1-to-1 ratio, and you will get about, if you look at the numbers, you create about 70 beats per minute for having this normal ECG. Again, this is an average number. What you see on the bottom picture is representation of something called junctional rhythm, which what you see, if before even looking at that, let's process the ECG. So you have flat, you have your QRS followed by T wave, a flat region, QRS and T wave. So from this graph, somewhere here, what you were supposed to have would be a P wave that is basically missing from each of these single parts of the graph. So P wave is representative of your pacemaker, which is also known or is created by your SA node, the big boss, right? The one that sets your heart rhythm. Now remember that if SA node was non-functional, that doesn't mean that your heart is going to stop creating electrical impulses. It will still create the action potential, but it's going to rely on what? A V node to do it. A V node is not going to be as strong as your SA node, so it won't be able to create the 75 beats per minute. What is going to limit the heartbeat is to about 40 to 60 beats per minute, which is typically not going to be efficient if you want to continuously keep a healthy circulation of the body. Now, the second option you have is something called, or second condition that you have is something called a second-degree heart block, where you have an AV node basically failing to do its job. Oops, sorry guys. AV node failing to do its job. So AV node is something that basically communicates with this SA node, and it gets these signals or electrical impulses and pass it down to the ventricle. So right here what you have, and this is the second degree heart block, focus on the vocabulary. So let's analyze the heart basically. So let's see, we have P wave, QRS, T, right? Then I have a P wave and nothing. And then I have what? Another P wave, a QRS complex, and a T wave. A P wave and nothing. Another P wave, and then a QRS complex. So in this, what I have is I have 2 P wave for every 1 QRS complex. This means that the AV node is failing to receive the electrical impulses coming from the SA node. So SA node is creating the P wave, but that P wave is not necessarily being transmitted to the AV node to create the QRS complex. So this is referred to as a second degree heart block, which we talked about it as being a partial heart block. Some of the SA nodes are passing through while the other ones are not. The last one, we also talked about this. This is called the ventricular fibrillation. And just by looking at the pattern, you see it's all over the place, right? There is no specific pattern that you can see, right? There's no QRS, P wave, T waves. Nothing is visible. This is where each of the electrical impulses in the heart, your intrinsic conduction system, is very disorganized. It's misfiring, it's all over the place, it's chaotic as it's used, and therefore it's very hard for the heart to actually act as an effective pump because it doesn't have the force that is required. This is typically seen in people who have acute heart failure or acute heart attack, or when there is an electrical shock which causes the electrical impulses of the heart to be all like a screw. The way to fix a ventricular fibrillation is basically use a defibrillator, which you all probably have heard of, with the goal of basically sending a shock wave through the heart and hoping that it allows all of the electrical impulses and the channels that create those electrical impulses to be resetted, and as a result, you hope that after a defibrillation, your SA node will be able to take over the action and basically create a normal sinus rhythm. Defibrillator does not always work, but again, the hope is that as you reset the channels of the heart, your SA node, which is your pacemaker, is going to take over and create a normal sinus rhythm. So I'm going to stop here, and then we'll continue with the next concept on your next presentation.